I think that the most challenging aspects in both adults and children with severe asthma are those who fail to respond adequately to either high-dose inhaled corticosteroids and are then going on to the oral corticosteroids. This is a real problem. We don't have good therapies for those, apart from adults where we're allowed to treat our patients with novel biologics. In children, this is much more difficult, so we have a gap. So U-BIOPRED was set up as a collaboration between the European pharmaceutical industry, the European Union, and 16 clinical centres across Europe, a number of patient groups, and 3 SMEs. The goal was to try and understand to a much greater extent by deeper phenotyping people in regards to their clinical aspects, collecting samples that would enable us to really get a handle on the immunopathology and the inflammatory processes that were driving an individual patient's disease. The goal, therefore, is to try and link mechanisms we derive from those analysis with clinical features that will help us either pre-select patients for clinical trials or purpose drugs to individually treat each patient. I think one of the real achievements that we managed to achieve or have in U-BIOPRED was that we had active engagement of patients from day one, who worked very closely with industry and with academics to work as a team. At the end of the 7 years of working together, you couldn't tell who was a patient, who was from pharma, who was industry, and who was an academic. And that really was an achievement. We all worked together for the same goal, with the same common aim. Patients were very good at informing us about study design, which way to go, and I think that was for me, that was one of the biggest achievements that we had. At the moment, we have high-dose steroids, long-acting beta agonists and other drugs which treat the majority of patients. Those who don't respond well to those have the option of going on to oral steroids, which are very toxic, and we should try to avoid taking people on that. So we want to give them biologics that target particular pathways. In order to do this, we must recognise who has which particular pathway that drives their disease. So we need to have biomarkers that tell us that your disease is is driven by a particular pathway, so we can precisely give a drug to you because your disease is driven by them. Phenotyping really involves a combination of clinical features that define the underlying disease, but we need to understand the mechanism behind that. You may have sputum eosinophilic asthma, but the reason for your sputum eosinophilia could be from different mechanisms. So if you target the wrong mechanism, then you will not get the adequate response. So in phase 2 studies, there's very exciting data on anti-TSLP monoclonal antibody that seems to be at least as effective as dupilumab, which is an IL-4 receptor alpha antagonist. I think this is going to be potentially of huge benefit because it covers a greater range of people. There's less pre-selection going. There'll be a number of other monoclonal antibodies in development, such as anti-IL-33 that will possibly be similar. I also think that for the non-T2 asthmatic patient, there is development of a number of different pathways, particularly with small molecule inhibitors targeting specific particular subtypes of PI3 kinase, such as PI3 kinase delta, and JAK-STAT inhibitors that will show great efficacy in clinical studies.